And they don't have a personality disorder, they don't tend to have a psychiatric illness, and they're not malingering, so they're not complaining that they have anxiety or they're in more pain because they want to receive some sort of finances for them. So I guess we have to see all people to view their pain as being real. Okay. And so far I've highlighted that there's an emotional side to living with chronic pain. It can affect what you do as a result of that. If you're depressed, you might not want to try anything else. It may mean that you present at doctors' clinics all the time looking for a cure. It could affect the way you view your condition. So there's a lot of links between the emotional, the thought process, and the behavioural factors as well. Okay. So most people with chronic pain are not psychologically different from the rest of us. They're just reacting to their situation in a normal way. So if we were in that situation and faced with a major change in our life, of course all of us would react in that way by complaining of being in so much pain or being fearful of increasing our activity levels because we think that it's going to make your pain worse. In actual fact, activity actually helps you to manage your pain. So much of their distress can be understood as a result of their symptoms or their disability. So in other words, they're normal people reacting to an abnormal situation. And the meaning of their symptoms is quite key, as I've stressed before. So or it could be a way of reacting against the way that they've been treated, because a lot of doctors might feel that they are imagining it. So I'll just refer you to the psychologists. They'll deal with you and assess you and then find out what the real issue is. But for a lot of people, that's just the way life is. I mean, I know what it's like to live with toothache. Imagine having that pain every single day. Of course, it will have an impact on how you feel. You won't be as cheerful, and you might not be very motivated to do the things that you enjoy. So it's bound to have a significant impact on what you do. So here are some common beliefs about chronic pain that patients might hold in terms of their belief that it's due to serious disease which has been overlooked. And in most cases, it's not due to serious disease. And most people have had lots of scans, and all it shows is that it's just wear and tear or something else, or that it's due to serious irreversible damage, or people will think that it means I'm vulnerable and I'm going to have further injury. Because I feel pain, that means it might get worse. I'll eventually end up in a wheelchair because of my pain. I'm going to become disabled. So these are all lots of ruminations that people might have because of their pain. Or that healthcare professionals do not believe that I'm in pain, and that's the reason why I keep moving from one doctor to another. Now, I learned a lot from my experience of working in pain clinics in the UK as a psychologist. We had a really good doctor there. He was very psychologically minded, and he was basically saying a lot of doctors don't feel that they can tell the patient that there's nothing more I can do for you, but instead what they will do is then ask the patient to go for another scan, and all that is maintaining the problem, which could be stopped earlier on by saying there's nothing more I can do for you rather than medication, and your pain might still continue. So it's quite hard for other people to communicate that to patients, and that might maintain the problem. So what is the role of clinical psychology then within chronic pain? Well, I think there's a major role to help patients to manage their emotional reactions, to normalize their reactions. Yes, we believe that you're in pain, and if anyone else was in that situation, of course, you would be feeling quite anxious or depressed. A lot of people might adopt a sick role, so they have actually gained quite a lot out of being in medical services because it means that they are cared for by professionals, which they might not get in their personal life. Having chronic pain has the potential to generate grief and loss issues because you're constantly comparing your current situation to what your life used to be like before, which I guess is quite normal, but it's a wrong comparison to make and quite unhelpful, which might then maintain depression. You know, making statements such as, well, life is so awful at the moment because I now have chronic pain, and I used to be able to do football or to, you know, run with my kids in the park, but now I can't do that because of my pain. So statements like that are likely to make people feel much more depressed. The personal meaning, as we've seen, is very important in physical health conditions. It's not just having cancer, HIV, or pain that's the issue. It's about what it means to be an individual rather than the condition itself. Psychologists can help people cope with change, so changing their lifestyle, which might go along with working with the grief issue, because in order to move to acceptance, you've got to go through the grief process. And that doesn't mean ignoring all the awfulness about having chronic pain. It's about supporting somebody dealing with all the grief in order to get to acceptance. And acceptance links in with psychological adjustment, because we all have to adjust to new situations. It's seen as a process that we go through life, where we incorporate this perceived physical disability into our current life view. Symptom management, because if you're feeling quite anxious, it's a normal reaction, but it can get out of control. So clinical psychologists have a role in terms of helping services to understand why people are reacting in a certain way, and also by educating patients to manage their symptoms a bit better. Now, in most pain services, most established pain services, is what is called a pain management program, which is very multidisciplinary. So the psychologist will take a role in working with all the emotional issues and helping patients to communicate a bit better with their loved ones. And there will also be other professionals such as doctors, physiotherapists and occupational therapists who also work alongside the psychologist to help somebody deal with emotional reactions. But what we're aiming for is that patients have a much more improved quality of life. So psychology does not promise to take away the pain. It's about learning ways of living with your pain, despite increased distress. So our aim is to help patients to be their own therapists so that you can improve your quality of life. Okay? Any questions at this point?
A question. It's actually a two-part question, but can pain be only psychological to an individual? Is it just kind of like unresolved issues that make them feel like they're in pain?
Well, pain is it's a physical problem, it's a medical issue. But what I'm trying to say is that it can have an impact on your emotional well-being. Unresolved issues might make your perception of pain appear to be much worse than it is, because if you're already depressed or you're trying to avoid some emotional issue in your life, and that pain might also, your perception of pain might be intensified. So for example, working in a service where people are experiencing a lot of pain in their, either in the buttocks or in the private area, that can have an impact on, that might bring back memories to do with past events like abuse, not in all cases, but in some cases. So it's a medical condition, but it can have an impact on your psychological well-being. Does that answer your question?
Yes.
Yeah. Okay, anyone else? No? Okay. Okay, well let's move on to diabetes. I told you I would take you on a whirlwind tour through a few different conditions. We can't cover everything tonight, so we've just selected a couple of topics. Okay, so most of you already probably know what diabetes is. It's a condition where a lot of people have high levels of sugar, and they're unable to metabolize the sugar with them because they lack the hormone insulin, which is produced by the pancreas. And there are two types of diabetes. Type 1, which seems to arise in young children and can affect anyone up until the age of 40, whereas type 2 is the opposite, associated with lifestyle changes. So on this one, so certain ethnic groups might be much more at risk of developing type 2 diabetes. It can also occur in people, ladies that are pregnant. They might have gestational diabetes. Okay, so I'll move on now to look at some of the psychosocial issues. Again, trying to highlight the role of psychology within diabetes. These are a couple of issues that might be problems for people living with diabetes overall. Those of you that know anything about diabetes, self-management is really important. So being able to monitor your blood sugar levels and making sure that your sugar levels do not drop to dangerous levels, where you have what's called a hypoglycemic attack. And so as diabetes is a progressive disease, there is an increased risk of having complications such as poor eyesight, having nerve damage in your feet, or your hands, for example, being at a much more increased risk of cardiovascular disease. But if you don't manage your diabetes well, your risk of having complications can be increased. Now with people like teenagers or maybe adults in general who maybe miss their insulin as well, of course their risk of complications is going to increase. decrease. There might be that fear of the future because now I've got diabetes, I'm not quite sure whether I'll develop complications or not. I'm not quite sure how to incorporate it into my worldview. There might be that fear of hypos because if you don't manage your diabetes well, of course you're going to be at risk of having lots of low blood sugar levels. And there might be that pressure to stay in control because what the medical team are concerned about is that people manage their diabetes well so they don't end up in hospital and they decrease their risk of getting complications. Loss is a huge issue because your pre-diabetes life, most people are able to do whatever they want, eat whenever they want, drink whatever they want, perhaps not look after themselves. So let's say the teenager was faced with type 1 diabetes. What impact do you feel that would have on them as an individual? Because we all know we've all been teenagers. Some of you might still be teenagers. What is adolescence all about? What was your experience of being a teenager? Were you all quite good teenagers? You were quite good? Okay. What about others? Amy, were you a good teenager? No? Okay.
Exploring, risk-taking, trying new things.
Yeah, for a lot of people, but not for everybody, yeah. And so most teenagers, the research shows that diabetes management is quite poor within adolescents because of they want to take risks, to be spontaneous, to be quite autonomous, and it's a huge transition that might occur at their stage in life. So having, let's just say, type 1 diabetes might lead to that sense of a loss of control. Prior to my diabetes, I was able to do whatever I wanted to know I have to monitor my sugar levels every day, and my fingers hurt having to do that 4 times a day, or I'm getting lumps in my stomach from injecting insulin, or I'm having to think more about what I'm eating. There might be that fear, loss of a sense of safety, particularly if you're having lots of low blood sugar levels, and it's ending up in hospital. So there might be that loss of freedom, not being able to do what you wanted to do because your perception of diabetes controls your life overall. And your constant focus on what my life used to be like before I had diabetes. Now obviously, not everybody is going to have these problems with diabetes because most people are able to manage their diabetes. But the people we see in psychology are the people who are struggling to manage their diabetes. It might have an impact on your level of independence because for teenagers you're having to depend a lot on your parents or healthcare professionals who are reminding you of the importance of managing your condition. It can have an impact on your sense of self. So a lot of teenagers have issues to do with their body image because some girls know that insulin contributes to weight gain, so they may skip the insulin in order to not gain weight. So that can be a problem. Or I've heard it before where teenagers say, I don't want to inject in front of other people because they might feel that I'm a drug user. And so having diabetes can have an impact on your sense of self and your identity. For some teenagers, it might also alter their plans for a career because for some jobs you cannot have diabetes and do that particular job because of the risk of hypoglycemic attacks. And the same issues might apply to adults overall. So let's have a look at the case of Donald. So this is Donald here, who is 17. And lecturing Donald unsuccessfully has been causing frustration for both his GP and Donald himself. Eventually his GP decides to refer Donald for psychological help to understand a little bit more about why Donald is so reluctant to manage his diabetes. Okay? So within the psychology session, the psychologist realizes that the problem started right at the onset of his, the peak of adolescence really, at the age of 16. And at the time of his diagnosis, that seemed to coincide with a major transition. So for example, it being a really important year when he had to take exams, but also his parents had separated at the time. So we can actually see that for this particular case, it was really difficult for him at the time of diabetes. And all the research would suggest that support is important, particularly when you receive a diagnosis, because you're in that sense of shock. And information and support is quite critical. So his thoughts were that, so in other words, the meaning for him of having diabetes is that having diabetes means that I'm ill and my body is weak. But people who have got diabetes are not ill, they just have a condition. If I think too much about diabetes, it will take over my life, so I better ignore it. I hate injecting insulin in public. People might think I'm a drug user, and my other thoughts are, why me? Okay? So that might lead him to feel quite anxious, fed up, and low in mood because of his perceptions of his diabetes almost ruling his life. And his physical symptoms might be that he feels quite tired because he's not looking after himself very well and quite lethargic. And so because of all of that, because he's got a very negative view of his diabetes, his behavior is that he doesn't take his insulin regularly and his sugar levels are very much erratic. Okay? So he's in and out of hospital several times. And he avoids thinking about his health. Now, prior to putting all this together, all we knew about Donald is that he's not managing his diabetes very well. But that doesn't mean anything psychologically, because we don't know the reasons why he isn't managing his diabetes. And so lecturing him is not likely to be helpful. So through further exploration, we realized that he's got very negative views with regards to his diabetes. So, approaches to making change. So after seeing the psychologist, Donald feels a bit better. He communicates his problems to his GP, who feels less frustrated and is able to express genuine empathy for Donald's difficulties. So this helps improve their relationship and encourages Donald to attend the diabetic clinic more regularly. Sounds quite straightforward, doesn't it? But in reality, you might have to go through several hoops before someone is likely to engage for most people. So Donald and his GP are able to openly discuss his fears and gradually move towards a much more balanced and helpful view of the situation, with thoughts such as, managing my diabetes better will prevent me from frequent hospital appointments and I can be able to get on with my life despite having diabetes. So that's a positive outcome, but for a lot of patients, you don't get that turnaround straight away because there are likely to be lots of other issues and barriers that stop us from trying to understand what makes it hard for some people. So psychological support has helped Donald to feel much more in control of his diabetes and he's able to improve his mood. So that's a positive outcome, and that's what we aim to achieve. Okay, any questions about that? No? How are we doing for time, the chair? Okay, okay. I'll finish my section and then I don't know where's Lindford? Oh, you're there, okay. You want to present immediately after that? We have a break and then you do your section. Okay. Our next well-stopped tour is looking at procedural anxiety, which is quite brief. So there is value, I think, in the role of psychology, particularly within medical settings. And I just want to say something brief about procedural anxiety. So there's a role for psychology within surgical services because most of you that go for surgery, you might maybe feel a bit of anxiety or maybe not. But some people generally find going for surgery quite frightening, quite anxiety-provoking, or going for a treatment where you're having to have lots of drips or injections. Now you might not start off having a needle phobia, but over a period of time, you might develop an aversion to pain, having your fingers pricked or having needles stuck into you all the time. For some individuals, going for surgery can lead to them feeling quite anxious about doing it because it's that fear of unknown. Anesthesia can make people feel a bit out of control, and particularly if they don't understand the procedures that they're going into. So information is quite crucial. And there's a role for psychology in helping people to actually talk them through what might happen. So that will include, spending time with other professionals, explaining to doctors or the nurses what the issues are for a particular individual to understand why is it that this person is having panic attacks every time they are going for surgery. In other types of surgery where people are going for reconstructive surgery, either for things like breast reduction or they have a known disfigurement, there's a role for psychology there as well. Because, again, there's a fear of unknown if you're going for a change in terms of what you look like. And so we need to work with people to improve their self-esteem or to make them feel much more in control of the decisions that they make. So psychological assessment is a key role, preparing people for surgery before they go for operations, helping them to ask the questions that they need to ask, rather than being anxious. I almost say, how can we put your anxiety into a question? What might you need to know to cope with this condition? So if you're anxious about, never waking up after you go for an operation, or that your operation is going to make your things worse, how might you put that into a question for your doctor or your nurse? And then you kind of get them to list down, I would like to know more about this surgery, and how much scarring I might have afterwards. And the more information you get, you might see a reduction in their anxiety. Okay. So I'd just like to present to you a brief, what is called a formulation of someone who, a real case, someone who has struggled who needs an operation to remove a mole on her face. But each time she is prepared for anesthesia to go in for surgery, she has a panic attack, which means that she never gets the surgery done. So this is someone who has an anxious temperament, but generally has a negative view of herself, and really doesn't really cope with change. So we know that as a factor that might make her quite vulnerable to panic attacks. So most psychological models of panic attacks explain that people normally have an internal or an external trigger that triggers off you feeling quite anxious. So in her case, her trigger is that the last time she had an operation, she didn't really cope very well with it. She didn't recover well. There was a lot of bleeding, and she was at home for quite a long time. So memories of that operation and the effect of anesthesia, the fact that she just felt so surreal, is leading to her feeling quite anxious. And because of that, her thoughts are that everything is out of my control, I'm about to die, I might not survive this operation. So these are the thoughts that she's having at the time as she's nearing theatre. And of course, when we're anxious, we have physical symptoms, so we might have palpitations, sweating, feeling quite tense. So what does she do when she's anxious then? Well, she panics, and she refuses to go to theatre at the start of anaesthetic. Now, most people that have panic attacks often misinterpret their symptoms. So rather than telling yourself you're feeling anxious, this lady's then misinterpreting her anxiety by saying, I'm about to die, I may not wake up, and that is keeping the cycle of panic going. So in terms of how you work with someone like that is trying to understand what the cause of her anxiety is, working with her on these thoughts. So how can we manage your anxiety better so you can have the surgery that you need? And things like behavioural tasks, you might then walk her to surgery and talk her through to make the environment less threatening to her. And work with her to have some much more anxiety management techniques. Does that make sense? Okay. So, what do clinical psychologists actually do then in physical health settings? Well, we know that psychologists assess, and we use a variety of methods to try and understand why someone is feeling distressed. So in order to do that, we use a clinical interview, which just involves asking questions to find out more about the presenter.